Hello, everyone. I am Diane Wade, the Marketing and Publicity Assistant at the University of South Carolina Press. Today, I have two of our USC Press authors here for what I have titled Authors in Conversation, where I sit down with a couple of our authors to talk about how the similarities in their books are in conversation with one another. Today, I have Shannon Ivey, author of Welcome to the Shit Show, and Sarah Singer, author of The Patient Empowerment Paradox. You can find links to their books in the description box of this video. So without further ado, we'll jump right in. Would you both mind giving yourselves a short introduction?
Okay, I'm Shannon Ivey. I am an author, a theater professor, and a patient advocate, and I live in Columbia, South Carolina.
And I am Sarah Singer. I am an author and a professor, and I guess also you could say a patient advocate. And I'm an associate professor of English at the University of Central Florida.
Wonderful. Before we jump right into our questions, I did send you each other's books, and so I would love to hear your first thoughts on what you thought of each other's book.
Okay, so I'm holding them together like this because I think that's funny. But I I feel like we are book cousins. Do you know in the I didn't know the press would say press sisters or something. There's press
I call
peers.
you siblings. Yeah.
I think we're cousins because in
Mhm.
many ways, these are books like a person with an MFA wrote this. Like you can tell
Mhm.
someone who's like, a storyteller person. This person, it has a PhD. This I have learned what rhetoric is. I didn't know from you, and it's fascinating because there are probably 1,000 overlaps where we could literally, I could draw a line directly to what you, I'm like, oh, that's like this. Oh, that's like this. So I'm in love with your book. I picked up a piece of fiction the other day and couldn't read it. I was like, man, bored. I picked your book back up and with my pen was like, where I could have been watching Netflix, I'm outlining your book, but that just tells you how nerdy I am. So I'm in love with your book. And I think read together, they would be really interesting in a course. I really feel like
Mhm.
these two could go together.
Mhm.
Mhm, mhm, mhm,
I absolutely agree. And I think when I picked up Shannon's book, the first thing that I thought to myself was, wow, this person really knows how to write. This is an engaging story. She's giving us just the right level of detail to keep us interested, but we're not bogged down. Because I think so many of us who write about illness, we're worried about making people too sad, or we're worried about all of the sort of twists and turns of the process and that people could get lost. I not only was I not lost, I was riveted. I was waiting actually for an oil change. I was like skimming through your book. I was, in all these different places because I like to bring things with me. And I'm an e-reader lady, so I'm always reading here. And I was so struck also by the clarity of your voice. And I think so often when people are ill, they feel that their personhood has been diminished. And in part, it has been because it's been taken over by appointments and medications and all of these things. And I was like, this woman's personhood is stronger than ever. And I think that's something that's just so incredible, and something that we should all really continue to think about as we encounter all of life's various challenges.
I love that you guys loved each other's books so much. I had a feeling that I knew that you would, and that is why I wanted you two to be my inaugural pair for this conversation. Because when I was working on both of these books, I was getting the scholarly version from
mhm.
Sarah, your book, and then that personal first person story from Shannon Ivey, and I'm like, I in my head I see it as a bridge. You're both on one side of the same bridge, and I'm standing in the middle of it, hearing this conversation, and I'm like, I've gotta get them in a room with each other or on a Zoom with each other.
Yes.
So I'm glad that you both enjoyed each other's books. So and that leads nicely into my first question. um, in reading both of them, something I noticed in both stories is the explaining away of symptoms. In your health journeys, how do you handle the seemingly first instinct to justify symptoms now on the side that you're on with your health journey versus at the beginning?
You want to go
Shannon, would you
first,
like to
Sarah?
start here? I do.
Yeah. All right, go ahead.
No, I'd like you to go first.
Oh,
I think you have a lot to say about this, and this is not something I've gotten particularly good at. So I stand to learn from you.
well, okay. So in the meeting before the meeting, we three were talking about, I'm not going to tell anyone's business because privacy, but how do we, and I'm just going to say people assigned female at birth, how do women, um, how are we socialized? We are socialized to be externally focused, not internally focused. And even like I've thought about this a whole lot, even as we begin to menstruate and go through other things, they're often like, this is what we've done forever. It's no big deal. Even though you might be a person who is laid out by these things, or like literally cannot go to school or work or function, we're still told that there's a legacy of women back to Eve where we have done this. So it's not a big deal. And I don't think this is done by other women intentionally, but it stays inside.
Mm-hmm.
And so a part of what I know I was doing was I had two family stories that helped me ignore these things. So I think
Mm-hmm.
we naturally listen, most people, to other family stories. One of them was Ivies have bad tummies. Like we know who can't have corn. It's like just a thing. I was the first to declare a food allergy and they still poo-pooed it. Now everybody's got food allergies. All my nieces and nephews. Like I just had to be the one they were like, yeah, Shannon's difficult. The other family story was because we're talking about colorectal cancer in my case. The other family story was women go into menopause early.
Mm-hmm.
So there's a third thing. The third thing is we have symptoms based on male experience. I
Mm-hmm.
won't do the PhD on this one, but when they say for colorectal cancer, you need to look for blood in your stool. And I'm like, well, that makes me think, sorry, everyone who doesn't know my world, I think like in the potty, you see blood. Women have been seeing blood since their first menses. Blood in the underwear. Sorry, everyone. It just blood when we wipe. There's blood is not alarming. I was not
Mm-hmm.
alarmed. None of these things were connected. So I thought it was perimenopause and the IV stomach. Turns out it was late stage colorectal cancer. So
Mm-hmm.
I would say what I've learned to do is to like really investigate my thoughts around it. And my thoughts could be, I don't have time to be sick. I have not great insurance that I pay for. I literally cannot have another cancer diagnosis. I go through all of the thoughts
Mm-hmm.
and I just check them based on am I gaslighting myself? And that's even before I get into an office, which from your book, and this is my bridge to you, you bring up a lot of interesting thoughts for me about drug seeking, like clinicians. If you change doctors, I didn't know you could change a doctor till I fired my first surgeon. Ooh, best thing I ever did. I didn't know. I didn't know that could be seen as drug drug seeking behavior or other clinician clinician oriented behavior that doesn't benefit the patient to get what they want. So I learned a whole lot about what when I am coaching folks or volunteering to support folks, how to encourage them to stand up for themselves and to get the diagnosis, get the treatment that they need, that they could be considered seeking something in some way. So anyway,
Mm-hmm.
I learned a lot from your book about this. So handing it over to you.
And I learned a lot from your book too. I mean, I think one challenge is, I had a very privileged experience. I was able to seek all of these other opinions. But if you are on Medicare or Medicaid, there are a lot of restrictions about which doctors you're allowed to see. And this dates back actually to really the progressive era and potentially earlier. Historians like Nancy Tomes have traced sort of the race and gendered aspects of receiving healthcare and about how, especially, with the onset of breast cancer and the sort of revolution in procedures. I think one of the patient advocates, Rose Kushner, her husband was a surgeon, and so they were piloting like a non-mastectomy surgery. Could they do lumpectomies? But through that
Mm-hmm.
time, there were these stereotypes about women saying being like surgery seekers, women who wanted all of these healthcare procedures. And we're seeing also that time there's a lot of institutionalization of women, particularly for behaviors considered outside of the norm. A lot of advances have been made since then in mental health medicine and all of that stuff. But as patients, we're still sort of left with these fundamental choices. Is my pain or is this problem bad enough that I'm going to go to the doctor's office? Two,
Mm-hmm.
what happens when I get there? How do I explain what it is that's going on? And
Mm-hmm.
then three, if my doctor responds in a way that I don't think is accurate, what do I do about that? And so I think these three sort of situations or questions are still fundamental to the patient experience, particularly for women, particularly for Black, Indigenous, and other people of color, people who have minoritarian identities that are at a disadvantage in the doctor's office. And so for me, I still think it's very challenging to decide when issues are important enough to bring up. And in my own diagnosis journey, if you will, I started having some symptoms that I truly tried to dismiss until they were completely unignorable. And it
Mm-hmm.
turned out when I casually mentioned them, it actually changed my whole diagnosis. These were things that not only was I not Googling about them, I just wanted them to go away. And I think, especially with so many of these conditions, we have those particular symptoms. But for me, my feet, my toes being stiff, I was like, I probably just wore bad shoes. I just need to get through this horrible foot period. I just have a little bit of psoriasis on my scalp. Okay, that runs in my family. But those two things together, finally, my rheumatologist said, Sarah, I think you actually have psoriatic arthritis. And if you know much about these autoimmune conditions, it means that I would then qualify for a whole different set of treatments because of a different diagnosis. So I want to encourage anyone watching and listening here, don't ignore those symptoms, but I do still think it's a question about when to bring up symptoms and how to approach doctors who might not pay full attention to them.
Ooh, can I pop one more thing back in this chat?
Yeah.
I had this moment where one of the doctors, at this point, I had vetted him pretty well. He knew what he was working with me. And it was my oncologist. And I will never forget, I was worried that I always thought I was stage 4 because I was so late stage 3 and I'd read all the studies about the possibilities of turning stage 4, which are like it's probable I would turn stage 4. And I'm 10 years out now. So not yet
Mm-hmm.
from this cancer. So he said to me, you are the patient with the most interoception, which means like can feel things in your body, which is why that port just drove me crazy. I was like, there's some in my neck. I'm drinking hot tea. And he was like, so that's your port. And what I needed was someone to help me translate because I was worried that what I was feeling was metastasis. And he was like, so I believe you. I actually believe you. But I don't think the story you're telling about yourself is the right one. So, what you're describing, Sarah, makes sense. He was right. It was not a metastasis. I don't know what it was, but it was a new pain, and my brain connected it, as brains do, especially sitting in an oncologist office, to worst case scenario. And I had shoveled all of this peer reviewed data into my head so that I could be, and this is where I'm going to hop over to my favorite phrase from your book. Yes, still favorite, citizen scientist, because I had
Mm-hmm.
become a citizen scientist. And if you put interoception, high stakes, clinical encounter with someone with higher power, much higher power than me, then you have this interesting moment. But I'm so glad he didn't gaslight me. And he said, yes, you feel it. Maybe it's not metastasis. And so that has helped me um, move them apart when I'm having one of those moments.
Mm-hmm.
Yeah.
That's really a perfect segue into the next question on rhetorical appeals that I was reading in Sarah's book, these bullet points in her preface. And I would like, Shannon, for your thoughts on these. So, Sarah says, as I learned about the canons of rhetoric and persuasive appeals, it occurred to me that my biggest health problem was rhetorical. How
Mm.
could I talk about my symptoms and experiences during a doctor's appointment without one, appearing like I was looking for attention, two, seeming like I was needling the provider for a particular diagnosis. 3, suggesting that I was a drug seeker. Or 4, offending the provider by bringing up the possibility of Lyme arthritis or recurrent Lyme. So, was this a similar conclusion you came to, Shannon, even though you weren't using like these words as you were looking for a professional who could help you? Did you find yourself, I guess the real question is, did you find yourself changing the way you were speaking to medical professionals as you were, like you said, you became a citizen scientist? What did you do when they did not particularly enjoy that?
I honestly wish I had become the person who navigated cancer before I knew of the diagnosis. I think it would have
Mm-hmm.
helped me.
Mm-hmm.
Um, I know that I am a smart person. I also know that I don't know all the things.
Right.
I have the privilege of knowing how to get information from behind paywalls because I didn't have the money to pay for all that. I know people. I might not be them, but so what I armed myself with, it's very much theater. It's like learn everything you can and then be in the moment with them.
Mm-hmm.
So with these clinicians, I would vet them. So with my second surgeon, the one who's in the book, Dr. Morrison, I brought him, just like my divorce lawyer, I brought him a binder and I just sort of looked at him and I didn't, I'm like, this is everything I've collected from your special interest. It felt like a neurospicy moment, and I'm
Mm-hmm.
like, here's what I've looked at. And I just sort of sat back. And that's when he leaned forward and was like flipping through. And I could tell he lit up. He was
Mm-hmm.
so excited. And then he realized what he needed to do if he was going to be my teammate. And he seemed to be interested in that. My internal med doc is just like this, very interested, very much about the new stuff and wants to talk about it. He said, do not bring this to your oncologist. He does not
Oh.
care. He does not want to hear it. He will not ever you're going to waste your breath. His
Mm-hmm.
job is to get you through the toxicity of chemotherapy,
Mm-hmm.
which will give you the best chance at survival at your stage. If you were earlier stage, I would not say this to you because you could choose not to have chemotherapy. Some people do and they're fine. You know, because you read everything. The best chances, if this is what you want to do, stay alive, then this is what we need to do. The only people with wiggle room are me and you. And that's where I learned how to sort of do all my research and then decide when to bring it out. I
Okay.
made some mistakes with my oncologist, and they
Mm-hmm.
would be noted in my notes. I was not going to try some of these things, but I asked some questions, and they were client asked about non medical use of blah, 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 blah. Oh, that was early before Dr. Morrison taught me what to do. He
Hmm.
taught me how to deal with the oncologist, to use the oncologist for what the oncologist was good at, which was he had a good bedside manner. He was very gentle, like he dealt with dying people all the time, right? That kind of personality.
Mm-hmm.
He was not a fighter. Dr. Morrison, Dr. Morrison would go to the line for you. And so that's where I learned who to be. I'm still myself, but I'm just like, I won't bring out the binder, do you know? That makes
Right.
sense. Yeah.
Yeah.
Did that answer your question?
It does. And I do think it's also still very related to that, like explaining away of symptoms of this concept of policing ourselves in the doctor's office of um even if we're not doing it with the intention of like being in the middle of a rhetoric PhD, it's still happening because I mean, you're going to respond to the way somebody responds to you. And so if you get so much pushback um, in how you ask a question or the types of information you're bringing, you're going to pivot. So it was really cool for me as a reader of both books to have Sarah, you putting right on the page, this is what was happening. And to see in Shannon and yours, you just sort of living it without the words, like without the
Yep.
toolbox, but living it. And then somebody else, and then I'm like, I'm sitting in this middle of, oh, I know what's happening. I completely understand. So and that's why I keep saying, like, I find there's this bridge between both your books. And what I find an interesting bridge between both is this parallel question about quality of life decisions. For Sarah, you are battling against the presumption that everything was in your head. And so you weren't getting needed treatment. And then for Shannon, you had the diagnosis, but now you had to ask the question of which treatment path would give you the ability to live a meaningful life and an authentic life. So, what are your thoughts on these two different yet similar barriers? Sarah, if you
It's a
don't
great
mind.
question.
Yeah.
Oh, sure. I mean, it's a great question. And I brought back to a quote from Shannon's book. On my version, it's page 76. And Shannon writes, no matter what it feels like to others, no matter how uncomfortable it is for them, your care is just that, yours. You even have the agency to decide if you want medical intervention and treatment. You get to make decisions for you. You are the protagonist at the center of your story slash the circle. Cancer is a formidable foe, but you get to decide how to respond to it. And I do think this is so pressing for so many people. And what's implied in Shannon's work here is that nobody wants to be sick. I do think that there's still, people kind of are questioning themselves. Well, why did this happen to me? What's going on? Theologian and historian of religion Dr. Kate Bowler, she would say, it's a myth that everything happens for a reason, and wrote a book with that very title. But here it's sort of like Shannon is marking out sort of what the possible paths forward are. It's like, are you seeking treatment? Are you not? And one of the things that struck me most in Shannon's work is thinking about not seeking treatment. What would that mean? What would that mean for her as a person, as a woman, as a mother? Who's
Mhm.
allowed to make choices like that? It's really very challenging. And hearing Shannon's process, I think she kind of draws back the curtain, if you will, to sort of show us what it was like to be behind the scenes and making those decisions. And I honestly think that's so rare. It's so unusual to get sort of the intimate take on someone's sort of choice in that way. But through this, Shannon is reminding us we have to sort of mobilize our own agency, whether or not we want to, and to remember that like nobody asked for this.
Yes.
I had can I hop in? I
Hmm.
had a friend ask me who read the book, do you feel like you were judged as a mother for people who read the book? That's what this question is bringing up for me. And I was like, what? What are you talking about? I mean, I felt in some ways a lot of the guilt and shame had to do with then my child's life being changed forever. But my child
Hmm.
is a child of divorce. So, like, look up those stats. So, we're like, this kid is going to be in therapy just like his mother. It's going to be okay. It's like, do you know what I'm saying? It's like, oh. And I hate to be flippant about it, but that question made me think, oh, wow, I wonder if people are shocked that I thought it through not getting treated because I was a solo parent. My
Hmm.
thinking it through was the pressure of, oh my gosh, do I have the resources to
Hmm.
get all the way through? Like that, and what little bit of money could I give to my kid for a college fund or something? Like if I'm going to
Hmm.
spend what little I have left in these like old dusty 401ks, if I can get them away from any medical debt, is it even worth it? So in that, I was really like, I think also the thing of finding out that I was worth more to my kid financially if I were dead. He would have gotten like 800 or 1200 a month for until he was 18. I had no idea. I was like, oh wait. So I was actually literally thinking about how much I was worth to him, alive or dead. And that makes me think of a book that's behind me. This book. Uh-oh, bringing another book in the chat. This is really great. The Cost of Living. This author, I follow her all the places. Emily Maloney. She's a English professor. So yeah, that's what it made me think of. It's like for my kid, what is worth the most?
Hmm.
Then I found the research about like, can I survive until he's age 12? I don't know why he was 7 then. And I'm like, okay, I have a 40-ish% chance, 37% chance of making it 5 years. So what can I do to try to make it 5 years so that internally to him, even though he's witnessing all of this, he will have the best chance? Because kids recover when they lose a parent. Parents don't
Mhm.
recover when they lose a kid. Anyway, all of
Mhm.
the data got shoved into the citizen scientist. And a lot of it
Mhm.
helped me make the decision to try.
Yeah,
Yeah.
that's beautiful. And really the gymnastics that you go through when you're in this situation, Sarah, you dealing with school and like playing that game of juggling, and then Shannon being a newly single mom and your child is 7 years old, which is very young. It's interesting how, well, for all of us, it's a bit of a shit show. It's it's a we all get our own unique brand of shit show, but it is.
Good thing
um
kids think poop is funny. So that was helpful.
and well, I do want to give you both the space for each of your particular audiences and genres. How did you decide to merge the personal versus the professional narratives? Sarah, you're writing this scholarly rhetoric book, but your preface is a first person narrative of what you are going through. And you, like you've said before, you are not a medical professional. You are coming from the rent and comp side of everything. So how did you decide to juggle that, like, this is my story, but here is also all of the scholarly information that I'm trying to impart? And then Shannon, you're writing a memoir, but like you said, you have all this data, you have all this research, and you both have decided to publish with a university press. So you're going to be peer reviewed. Shannon, how did you decide to bring in the scholarly aspect to a first person cancer memoir?
Sarah, you go first. I'm holding your book.
That works for me. I think this question came up for me as early as at my dissertation defense, which,
Mhm.
anyone who's written a dissertation, a master's thesis project, an MFA project, for most of us, that is sort of the beginning of the big project. It's sort of like the root, and then it takes a longer time, in my case, many years, to really take hold as a book. And so I was asked at the time, like basically saying that like the voice of the dissertation is inconsistent because some chapters use this first person perspective and others did not. And at the
Mhm.
time, not to say I didn't notice it, it was just, there was so much going on. And I thought, well, it started with my own story. So I couldn't not start with myself. That felt inauthentic to me as a writer, as a scholar. And then when it
Right.
came to writing the book version, I thought, well, the thing people connect to stories. After, I would consider myself a medical humanities scholar or health humanities. And so much of that area is just talking about people's stories. We're rooted in experience. My background is in women's gender and sexuality studies, and so much is about, for example, Joan Wallach Scott, the evidence of experience. And so, that really for me was really central. But I felt like at the same time, there's so much critique in, not exactly in my field, but say the scholarly community broadly of autoethnography. And I think many scholars, we worry about being too navel gazing, is I think the expression. And so
Uh-huh.
I knew my story alone, for my purposes, wasn't going to be sufficient. And it's true, it also didn't provide sort of the evidence that I was really looking for. I knew this had happened to me. But in order to really make an argument about it, I had to bring in research from, other resources. I really had to sort of put my story in conversation with others. So it was challenging. It was exciting. And honestly, it was very sad because it was really sad to know that so many other people had suffered in the same way that I did. And in hearing these other people's stories, I was very struck by their main goal, which was to help other people not suffer even more by sharing their story. And people shared terrible and embarrassing things with me about how illness had destroyed their lives, and they would have shared even more, whatever it took to try to help other people get a diagnosis faster, to help people realize they were sick, to learn about the intricacies of Lyme disease. Um, yeah, I don't know. Shannon, I'd love to hear more from your perspective because, sort of, as a writer, also as a theater professor, I think your first person just was such a strong component of your memoir. It was like you were leading the way, and then, but it wasn't just you. You backed up so many different claims with a ton of research. Clearly kept you very busy for several years after some very busy years of experiencing the things that happened and were detailed in the memoir.
That like push from knowing so many people are dealing with it has been behind me since I found Colon Town. Colon Town is, and it's, I'm amazed that people don't know about it. I was at a colorectal cancer conference in Charleston last week, and I kept saying, like, tell me about Colon Town. And it's for patients and caregivers of people with colorectal cancer. So that's when I saw that I was not alone. That's when because I really was like, I have never heard of a woman at 42 with this who looks like me. I couldn't find any books. I read Eve Ensler's In the Body of the World. I think it was uterine cancer. But of course,
Mhm.
she talks about having different privileges. I just could not find anything. This before Kate Bowler wrote. Couldn't find anything about early onset, but all the stories were in Colon Town. So for 10 years, and I've been the South Carolina volunteer patient coordinator for our little part of Colon Town for years. I watched what was now known, like we know now, that colorectal cancer is the number one cancer killer of people under 50. That just came out from the American Cancer Society in January. So my book stats that came out in February are already a little bit old. But there is a section when I'm like, this is going to be number one. It's somebody is going to, it's like breast cancer at this point. Somebody
Mhm.
it's going to be affected by this. It is not a secret anymore. Y'all just need to be brought into the chat. The reason why I chose it was a wonderful moment of being at a writer conference, which I still hilariously don't identify as a writer, although, hello. I was at a writer conference with this, like, I write in essays, like Mostal story slams, but on the page. This is how I go back and
Mhm.
forth between the two. Very happy place for me, 5 to 8 pages, personal story. I love braided essays because nerdy. Um, that's when I met Aurora at the University of South Carolina Press. She has a new title. She's the director of, Diane, what is she the director of?
Editorial directors is her new title.
Yeah,
Yes.
very fancy. She was talking about, and as a person who has been around Columbia University Medical Humanities Narrative Medicine, I have been up at Columbia University in New York so many weekends. I've written so many grants to be right there, to be beside a clinician looking at a piece of art and then talking to each other, flattening hierarchies, which I realized that's what I do in the room. Not to take away their power, but to try to get on the same team with them. Like, what are we looking at? So I knew that there was a need. There is a high uptick, like this is coming. So I had like a proposal numbers ready in my brain to talk to Aurora. And I'm like, you might not have heard of this. This
Mhm.
is now. This is right now. I had the essays. What I needed was a vehicle or like a process to get it both into the scholarly. They weren't going to look at it without peer review. They weren't going to talk about this book in their classes without data. I know
Right.
them. They're my friends. I'm like, y'all need this. But
Mhm.
also, I needed a book that had enough in it that it could walk out into the world and do. I say it's a little book with a big mission. So I had to test it with millennials because there's a birth cohort effect with millennials. So
Mhm.
boomers were like, that title is terrible. Gen Xers are like, millennials are like leaning in. And I'm like, there we go. That's what this is supposed to do. So I put all my tools and then connected well with Aurora. And then she bravely went on this process with not a associate professor, with my messy self. And now here it is out in the world.
Mhm.
I'm still really glad I went that direction with this book. Really glad.
Yeah.
Grateful.
Well, another way that makes you both cousins, Aurora, was both of your acquisitions editor. Hey, we know what we're doing over here. Um,
Mhm.
I do want to give you both the opportunity. Is there anything that we haven't touched on about your books that you really enjoyed about each other that we haven't talked about yet?
I have a new parallel that just came to me after I put the
Okay.
fiction down and picked up your book. You talked probably later in the book about the like peer reviewed. So there's this funny thing about peer reviewed, and then we're getting peer reviewed information from each other.
Yeah.
So I found that parallel fascinating for me in Town and then behind paywalls, and for you in looking at how do these organizations put out information, whether it's in journal articles or like how does the public get to them? So I'd love to invite you to that chewing of a thought right now.
Oh, absolutely. I mean, I think the challenge with peer review is that, it's something also you and I both went through with our books. And on the one hand, it is this incredible it's just this huge compliment in a lot of ways that someone would take the time to read your work and critique it. And you can tell I spent a lot of years in graduate school when I see critique like that as a major act of love, like someone who's going to spend time making the book as strong as it can be, addressing the counter arguments, pointing out problems. And the problem with peer review, as we know, is it can be slow. And certainly with monographs, of course, you're talking about hundreds of pages that someone needs to review. But even with journal articles, it could be slow, but also it could be very, very fast. And so in the sciences, in health and medicine, a lot of the journals publish, multiple times per month. Peer review could be so fast. And so the challenge is that for so many of us, the research is old as soon as it's published. We also have there are all these pre-publication opportunities. And patients are caught in the middle because, as you were talking about, Shannon, so many patients don't have access to the databases where these peer reviewed journal articles are stored. They may only be able to access older articles. They may only be able to get article previews or abstracts. And so by the time they go to leverage that work in their sort of personal research about the condition with their doctors, sometimes it's already too old. Or we have trouble understanding the context of the research. I actually had this very recently. I was talking to my rheumatologist about some new medications, that are being paired with psoriatic arthritis medications. And I said, what do you think about these pairings? And she said, "Oh, Sarah, look at that data more closely. The challenge here is, look at the control groups. How many people were here? Yes, this was a big study. No, you don't really fit into either of the, sort of tested groups." We were sort of joking about it because I was sort of pushing her and saying, "Oh, what do you think? I saw that article. I saw the headline. I know you did too." And she rolled her eyes at me and said, "That is not appropriate for you." But in the very short span of the clinical appointment, there's often not enough time to even have that kind
Mhm.
of conversation. And I'm really fortunate my rheumatologist has taken such good care of me. I started with this same rheumatologist. I've come back to her later in my life. We have a really trusting relationship. She actually asked me before my last appointment, she messaged me on the portal and said, "What blood work do you think you need?" And I was like, wow, this is a new opportunity in our relationship. I was really unprepared actually for that level of partnership, which really is about the question that I have for Shannon coming up. And so I think it's just really challenging for patients. On the one hand, we, scientists and clinicians hold up peer-reviewed research as this sort of best type of research. But for so many patients, they learn the most from their peers, the peer-reviewed research in this way. One of my patient participants called this anecdata. And that was really the thing that helped them the most was looking at the anecdotes, which really are a form of data. So we're all kind of caught in the middle. It is thus a little bit paradoxical. And so, Shannon, I am interested to hear more about your sort of changing relationship with healthcare providers now that you've had this experience, which is really a set of experiences. There have been so many doctors you've seen, so many different types of protocols. What happens when you walk into a clinical encounter now? How do you do so in a really different way? Are you able to leverage some of these things that you've learned? And sometimes do you also find that new problems just create new opportunities for new questions?
I'm thinking about a moment Of course, there's like a quick story. I'm thinking about a moment and when this changed. I had, because of my complicated medical history, I was told that I needed like to stay near providers who had some sort of oncological background.
Mm-hmm.
So at the time, it's probably 5, 6 years ago, I had like the oncology OBGYN, just, because things are neighbors. And so you never know. So she, during the exam, she's very smart. She's also really good at fertility. So her OBGYN office is like baby pictures everywhere, which, okay. Um, and she said the wrong cancer. She started, I'm nerdy enough that I knew she had my diagnosis wrong. She was talking about anal cancer. And I said, I like literally sat up a little bit and said, no, that's Farrah Fawcett. That wasn't me. And then she argued with me a little bit. That's an unusual time to be arguing. But I said, no, no, no. It wasn't anal cancer. It was colorectal cancer. And that's just different. And so later she sent me a message and she was like, I'm so sorry, you were right. I know I was right. I'm like, I don't need that testing, because she was trying to connect it to HPV, which in the book,
Mm-hmm.
I get interrogated about that a lot. That's like a common misperception.
Mm-hmm.
So I'm like, no, it's not HPV. So that's fine. But I mean, feel free to run a panel. That's just not what we need to do. I think what I've learned to do is to stay well seated in what I know.
Mm-hmm.
Like that's again back to like, I don't need to gaslight myself on what I know. So when they're wrong, I'll be like, I'll lightly correct them and give them the other thing. I won't go into a long monologue that I've done here. But I've learned to stand firmly in knowing that no one clinician knows everything. Not
Mm-hmm.
even my super brilliant, like probably Mensa smart internal med doc who's good at connecting. Well, I'm also good at connecting. So I just need to remember I'm the whole patient.
Mm-hmm.
I'm it. So whatever they're bringing into the room is from their side. Studies of bias and all of that. They're bringing their own stuff in. So I just know enough to smell it, and be like, no, that's incorrect. And change providers if I need to. I actually downgraded from like a OBGYN person. I prefer NPs. I love nurse practitioners for what I need. I don't think I need all that. So I'm making some choices. We'll see in 10 years if it worked out, about clinicians who are more centered in the patient experience. Yeah. Okay, that
Mm-hmm.
was my rambly way of saying all
Mm-hmm.
that. Yeah.
Oh, it's so interesting. And I think people don't think about that, as you're saying. Like, when do you find a provider who's more of a fit for you? And the
Yeah.
fit has to do with their expertise, but also their patient manner, their work with patient provider communication. It's not just sort of the degrees after someone's name. And I will say, in interviewing a lot of chronic Lyme patients, people were talking about this issue of Lyme literate medical doctors. And for those of you who are listening who may not be familiar, a Lyme literate medical doctor is sort of a self-selected title that usually providers apply to themselves to signal to people that they believe that Lyme disease can be chronic and real, and also often to signal that they are willing to try potentially less tested or untested and more experimental treatments that typically sort of address the whole body. And this was a main kind of complaint of the patients that I interviewed, was to say, every time I go to the gastroenterologist, they think it's a stomach problem. The neurologist thinks this is a brain problem. No one is putting all of these things together. So it really still puts patients in this terrible paradoxical position. They're suddenly getting all of this expertise, but no one is helping them sort of circle up things. No one is helping say, okay, well, what if this is related to that? And what's really hard is with conditions, like colorectal cancer, like Lyme disease, like other infection associated chronic conditions, it's not always obvious what your ankle has to do with your hip or what your hip has to do with your stomach. And so there's still
Mm,
so much labor that patients have to manage,
mm,
that they have to perform. And Shannon, I think your book speaks to a lot of that, with compiling your binder, with deciding who to see and what to say to them. I just think, unfortunately, this is an ongoing problem for patients, but it sounds like you've come up with some pretty good solutions. And that is kind of narrowing your focus on providers who are sort of appropriate to the skill level of the issue at hand. That you're saying, you know what, I don't need to see all oncological focused providers anymore necessarily. I don't necessarily need to see MDs. I need to see people who will really see my whole personhood and help me reconcile all of those things.
I was sitting beside a retired gastroenterologist at the conference. He was very funny man. He liked to talk about poetry and singing. This is what he likes to do now. But he told me the day before the conference ended, he was like, "You would not be here 10 years ago. There is no research about what you are now experiencing because it is new." And I'm thinking, I think that connects us too. There is, as they discover new things and new clinical approaches to this and that, we become the new thing. But then no one studied us. And so part of what we are doing, you bring up so beautifully in your book, is we become a scientist of our own experience and draw from people like us and what they like. Thank goodness people told their stories in Cohentown. I would not have found Dr. Morrison without it. I wouldn't have asked this, I wouldn't have asked that, but I learned from their stories. So I don't know. I'm just so grateful that citizen scientists like you are here and the people who share their stories continue to evolve, whether it's peer reviewed or peer reviewed. We get access to something that will help as we are on the front lines of new or highly contested medical situations.
Absolutely. So this has been a wonderful conversation, and I'm very glad that the two of you were willing to take the time and do this. I'm so happy that you both loved each other's books. And thank you to everybody who is listening, who is watching. Like I said, all the book information will be in the description below. You can find both of these books at uscpress.com. So thank you, everybody.